Hi everyone. In today's lecture, we're going to be covering the second component of our topic, cancer, and we're going to be looking at biology of cancer and tumor spread. We'll start by looking through a few definitions, the first two being a review. A mutagen, you should recall, is an agent or substance. It could be radiation or chemicals that are known to cause genetic mutations. A carcinogen, on the other hand, is going to be a substance that has the ability to cause cancer in living tissue. Carcinogens can be classified or categorized as being genotoxic versus non-genotoxic according to their specific pathogenic mechanism. Starting first with the term genotoxic, so this is something that's toxic or poisonous to the gene. It has the ability to alter DNA, alter chromosomes, and ultimately affect the integrity of our DNA. So genotoxins then are mutagens, but they're also carcinogens. Non-genotoxic, on the other hand, these have no direct interaction with DNA, so it's not directly causing DNA mutations, but they still do cause tumors and cancer. And this occurs because instead of affecting the DNA itself, they disrupt cellular structures. They can change the rate of cell proliferation, speeding it up. They could contribute to processes that increase the risk of some sort of genetic error occurring. So they still cause cancer even though they're not directly affecting the DNA, but because of that, they can be difficult to detect because we can't look for those DNA mutations like we can with something that is genotoxic that alters the DNA. So instead, with non-genotoxic substances, they're going to work at maybe encouraging the cell to grow, preventing the cell from dying, causing it to proliferate out of control. Can a mutation be inherited? Well, it really depends on where that mutation is. If the mutation is on the somatic cell, so your body cells, then it cannot be passed on to your offspring or progeny. Mutations in the germline, though, can be passed on to future generation. So we're referring to your gamete cells. Now in the diagram here, we can see an egg and a sperm, and these are gametes or germline cells. You can see that if the egg has the mutation shown here, then the fertilized egg will take on that mutation. And then that mutation will be present in all of the offspring's body or somatic cells, but it won't necessarily become an issue. At the bottom here, this pedigree chart, we can see that there is no cancer in the first generation, and there is no cancer in the second generation, but you can see that cancer has developed in the third generation, passed on to the fourth and the fifth generation, and this is likely that there was some mutation that was present that affected future generations. Some viruses have been known to cause cancer, and the example that we're going to look at is the human T-cell leukemia lymphoma virus. So shown here. So it's a virus, and as you can read at the top, infection by an oncogenic virus is far from sufficient to cause cancer. So let's break this up a little bit. Onco typically refers to tumor, but it's most often used when we describe cancer. So in this case, oncogenic means cancer causing. So if you're exposed to a virus that causes cancer, it does not mean that you will necessarily end up with cancer. If you're infected with this HTLV, you will not necessarily be affected with leukemia, lymphoma of the human T cells, but it's possible. So HTLV is a retrovirus. A retrovirus will actually insert itself into the human DNA, similar to what we described when we spoke about HIV. Transmission of the virus can occur either vertically or horizontally. So vertically would refer to it being passed on to an offspring, whereas horizontally means mechanisms such as breastfeeding, sexual intercourse, transfusion, blood transfusion, exposure to infected needles, among other things. Then after the infection, what are some of the effects? Well, they might be asymptomatic. There might be no symptoms at all. But a small amount or a small fraction can be affected with adult T-cell leukemia and lymphoma many years after infection. So this makes it very difficult to determine where it came from and from who when it's developing many years later. We spoke about viruses causing cancer, and we looked at one particular example, but now we're going to look at bacteria because it can also cause cancer. And the example we'll look at is Helicobacter pylori, or H. pylori for short. It is a bacteria that infects more than half of the world's population. It is one of the most prevalent infections and the most common cause of gastric infections. We're talking about the stomach. It is more common in some areas of the world than others. This has a lot to do with different sanitization found in developing world compared to developed world. But even in the developed world, it is present because of not washing hands properly before consuming food, and not washing your hands after using the bathroom. These can cause this bacteria to get into your digestive system. And people that have H. pylori and have symptoms of H. pylori are at higher risk of getting gastric cancer. So what this bacteria does is it buries its way into the mucosal lining of the stomach, which leads to gastric infection. Now, a lot of people can fight off this bacteria on their own, but in other cases, it can lead to the point where they develop peptic ulcer disease and chronic inflammation of the stomach. So chronic inflammation of the stomach would be referred to as gastritis, inflammation of the stomach. And then these ulcers are actual breaks in the mucosal lining that can bleed. And if they are present, this inflammation and ulcers are present either intermittently over time or present for a long time, it can predispose you to changes occurring within that gastric tissue that can lead to either gastric carcinoma or MALT lymphomas. MALT is a tissue that's found all throughout the digestive tract, and it serves an immune function. It stands for mucus-associated lymphoid or lymphatic tissue, and it can become cancerous. So again, many people can fight off this bacteria, or they don't have any symptoms of it, so it's not really a problem, whereas others will have symptoms, and it can be treated with antibiotics in order to prevent any chronic issues. When a person sees their doctor for issues regarding possible cancer, there are numerous variables that need to be considered. First is the pathologist's report. If deemed clinically necessary, a tissue biopsy of the concerning tissue is going to be performed. So the tissue is removed, prepared, and analyzed by a pathologist. You would also need to consider physical findings. So we're talking about the clinical manifestations that something is going on. What exactly is that patient presenting with that leads you to be concerned that they might have cancer? Lab tests, we talked about this in class, so looking at different markers, whether you're looking at the blood, the urine, the cerebral spinal fluid, for something that could indicate an abnormality. Imaging studies such as CTs and MRIs, we'll look at this later. Early diagnosis is very important because the survival rate is much better. That's pretty obvious. It helps also with the treatment plan. Many more treatment plans can be offered in the beginning than at a later diagnosis. There's obviously going to be an improved prognosis in most cases if you can diagnose early. And lastly, advantages of early diagnosis include giving a common language for exchange of information among family members. When health professionals look at tumors, there are different ways you can classify a tumor, and the three most common ways are listed on this slide. First is the source of the original or primary tumor. This is important when looking at tumors that have spread to other organs. You need to have an understanding, where did it originate? We can classify through the TNM staging. So this is tumor node metastasis, and we'll get into that more soon, as well as tumor grading. This is done under a microscope. Tumor grading includes observing the extent of differentiation to well differentiated. Is it moderately differentiated or poorly differentiated? Do the cells look as they normally should? Do they look moderately like they should, or are they becoming unrecognizable? Let's have a look at tumor differentiation or tumor grading. This image here shows tissue that is normal, outlining it to changes that are outlining the changes through to the point of undifferentiation. So in the first example, we have what's normal, so normal size, shape, and order. In the second image, there's some order. Some cells are similar to normal and similar to each other, but not all of them. It's still recognizable. In the third, cells are becoming much less recognizable. In the fourth, they're losing their cell shape, they're losing their cell size. And in the fifth, it looks nothing like the original tissue. There's loss of size, shape, structure, organization. And as cells become less differentiated, we know that they become less normal also in terms of their function. And sometimes it isn't until later stages, when somebody's tissue has lost its normal function, that the clinical manifestations are strong enough to bring a person in for testing or to warrant a doctor to begin testing. In many cases, in the second grade, people do not even know that something is wrong because the cells are still fairly well differentiated and functioning normally. So of course, you don't need to be able to recognize these images, but understand some of the trends that I'm speaking about. So then we can grade tumors from 1 to 5, depending on how abnormal they look under a microscope, taking into consideration the structure, how the cells in the tissue are appearing, and even the pattern of how these cells are growing. We talked about high mitotic index in our in-class lecture. The next method of classifying a tumor is through the TNM staging system. T standing for tumor, N for node, referring to lymph nodes, M for metastasis. We're going to outline some very brief details about what each stage involves, but we're going to look at more detail on the upcoming slide. In stage 1, cancer is confined to an organ of origin. It is still in the area that it developed, and it hasn't invaded other structures. That's obviously the best time to catch cancer. Stage 2, usually still a very good prognosis. This is where it has invaded tissue in the area, so local invasion. Stage 3, cancer has spread to regional structures. And then stage 4, cancer has spread to distant sites from, say, the liver where it originated to the lung, or the prostate where it originated to the bone. So let's make a little bit more sense of this and the TNM staging system. Now, this is specifically an example of the progression of breast cancer. And we're going to look at what TNM means and apply it to the different stages. Again, speaking specifically of breast cancer. Now, in the case of stage 1, what we may see with breast cancer, stage 1 breast cancer, is that the tumor size is either 1 or 2. So we would say T1 or T2 for tumor size. And that's because if we look over here, the lesion is less than 2 centimeters in size here. At T2, it's 2 to 5 centimeters. And it's the third one that is invasive. And we know with stage 1, cancer is confined to the area of origin and not invasive. So we would give it a number T1 or T2. In terms of nodal involvement, we're going to, in this case of breast cancer, say that it's likely going to be N0, meaning that the nodes are not involved. There hasn't been spread to the lymph nodes. And then for metastasis spreading to other organs, this would also be M0 because there's no metastasis with stage 1. Now with stage 2, what we can see is in terms of tumor size, we would see some invasion. And in particular, invasion of the skin in the area, again, talking about breast cancer, and or the chest wall has been invaded, which is represented in this image. And that lines up with what we've stated, locally invasive cancer. So in this case, in terms of N, it could be N0. It is possible that there could be nodal involvement though. In most cases, if there is, if we look over here at N1, there might be a mobile node, meaning a movable node that's involved. And then M, metastasis, would be 0 with stage 2, because we know spread doesn't actually occur to organs until stage 4. So stage 3, this is where it's interesting. In terms of tumor size, it could be 1, it could be 2, it could be 3, but the key feature was that there has been some spread to regional structures. Now that's not the same as talking about distant sites. We're talking about sites in the area, which would be your lymph nodes. So we could have T1, 2, or 3 for this stage, for stage 3. For lymph nodes, though, this is where we're definitely getting involved with the lymph nodes in the area. They could be a combination of being mobile and fixed. Now, when we look at M, we know that would be 0 for stage 3. But stage 4, tumor size can also be anywhere from 1 to 2 to 3. Nodal involvement can be anywhere from, believe it or not, 0 to 1 to 2. But the key feature with stage 4 is that somehow this cancer has gotten into, in this case, likely the bloodstream or the lymphatic system and spread to distant organs. And so when it comes to M, the key is that it has metastasized or spread to other organs, but we can either have a situation where you can see that it has spread to another organ, or you can have M2 where there are a lot of suspicious areas in the body, more than one suspicious area, likely that is thought to possibly be cancer. This slide demonstrates the relationship between survival rate and stage of diagnosis. In this first graph, we're going to look at low grade versus high grade. And we're going to go back a couple of slides to remind you of low grade versus high grade. Remember our grading system. And so what we can see here is with low grade, we know it's going to be more differentiated, more like normal cells, and obviously have a better, because of that, have a better prognosis than high grade, which is less differentiated with a poor survival rate. And so approximately looking at this image, you may have up to say twice the survival rate, the 5-year survival rate, when you have low grade versus high grade. So early diagnosis is key. Now in the second image, if a person is diagnosed with malignant melanoma in stage 1, they have a 90% or so survival rate. In stage 2, this drops to about 65%. In stage 3, this drops to around 15 to 20%. So you can see a pretty drastic drop in 5-year survival rate in people that are diagnosed early versus late. So this is a great reminder to check your own skin, to observe your family and friends' skin, and if there's anything that looks concerning, see your doctor, see a dermatologist, because such a difference with early diagnosis. And of course, make sure you wear sunscreen and protect yourself. Now we're going to talk about phases of tumor spread. The cell first needs to be transformed. The DNA in the nucleus is going to have some sort of genetic alteration, which we'll start seeing in the early early phases of development. This genetic alteration can lead to the encouragement of cell growth and proliferation. Remember, we talked about the clonal proliferation model. So the proliferation, the cell growth, it's being encouraged to occur at a much higher rate than is normal. And we also know that cell death is going to be discouraged. After growth and proliferation, local invasion can then occur, and we know that would bring us into stage 3 and beyond. And here's where we're going to see angiogenesis, which is the formation of new blood vessels, destruction of basement membrane and surrounding tissues, that's the invasion component. We're also going to see changes in cell-to-cell adhesion and motility. So this would be how changes in how well cells are adhering to each other in normal tissue, and changes in normal movements, and of course other behaviors of cells. In terms of distant metastasis, overall it's considered rare for somebody to be diagnosed with stage 4. But once distant metastasis does occur, and we're into stage 4, some of the features that we would see at this stage include preferential growth of the cancer cells in certain organs. And what they'll do is they'll release these different factors such as growth factors and chemokines and hormones, chemotactic factors, all different chemicals that will encourage its growth and its survival. Chemokines are just a class of cytokines. Okay, even though we think of cancer as being something that doesn't follow the rules, they're independent, they can do their own thing, there is actually some rules when it comes to the organs that they can commonly metastasize to. And that's called the seed to soil hypothesis, which we're going to discuss next. All right, let's look at the seed and soil hypothesis of cancer metastases. Women with advanced ovarian cancer were ending up with ascites, which is an accumulation of fluid in the abdominal area. So they can almost look like they're pregnant, and having this kind of beer belly so-called look that people that drink a lot of alcohol can end up with. And this is called malignant ascites because the peritoneal fluid it's filled with malignant ovarian cancer cells. So this causes an increase in abdominal pressure. Obviously, if there's more of a substance in there than there's supposed to be, there's an increase in pressure. Surgically, this peritoneal fluid would be shunted into the venous system in order to relieve some pressure, but then it was discovered that although this relieved a lot of the abdominal pressure and the subsequent pain, that billions of ovarian cancer cells moved into the bloodstream. The common viewpoint used to be that cancer cells needed a pathway to spread, and the usual pathway is the vascular system or the lymphatic system. So one would assume that this would cause metastasis, meaning that shunting all of these cells into the blood would cause it to metastasize elsewhere, but it didn't. So there must be something else that happens, and that the ability to spread just isn't this simple. And out came the hypothesis of seed to soil, meaning that the seed must be just right, the soil conditions must be just right in order for cancer to basically set up shop and develop. So the cancer cells must really surmount multiple physical and physiological barriers in order to spread, survive, and proliferate in distant locations. And the destination, the soil, must be receptive then to the growth of the cancer. In this diagram, you can visualize the process of metastasis, the sequential process, which begins with transformation, where you end up with larger cell formation. We talked a lot about that already. And then this clump of cells will form new blood cells once the tissue is large enough. And we know that process is called angiogenesis. Now, some of the cancer cells can start to invade, they can start to break off and travel through the circulatory system and the lymphatic system. They can circulate around, but they can also form an emboli, which is a blockage-causing piece of material inside a blood vessel. It can end up sticking to the blood vessel wall. Then they can migrate out and spread to other areas that is an appropriate environment for continued growth, such as the lungs. And so you can see cancer setting up here in the lungs. I'll now discuss the concept of cancer stem cells. If we look at a primary tumor and we break it into its different components as shown here, called cell sorting, you can see that this type of cell here represented in red is the cancer stem cell. And this can become a secondary tumor. The theory is that if we can use stem cell specific therapy, so specific therapy for these stem cells, then we can kill the entire cancer. With conventional chemotherapy, all cells can be killed off except for the cancer stem cells. So over time, since stem cells still exist within the body, that's why cancer can reoccur and progress just as it did before. Let's take a step back and look at cancer invasion. So in this third image, this is an in situ neoplasm, and it does not resemble normal cells, and even the ones that are the cells that you can still see are dysplastic. We have loss of structure, so therefore we have loss of function, but invasion hasn't occurred yet. It's still in situ, in place. But then this invasive neoplasm has invaded down into the muscularis mucosa of the gut. This is an intestinal example from our in-class lecture, and the submucosa beneath it. Now, how does this happen? How does this invasion happen? Well, let's look at some of the basic steps. First of all, the cancer has to attach itself specifically to the basement membrane. So remember, the basement membrane is going to be this part, the foundation that the cells, in this case epithelial cells, lie on. So attaching itself to the basement membrane and or the extracellular matrix, so the stuff around the cells. And then what's going to happen is dissolution, dissolving of the basement membrane. And this is done by degrading collagen with collagenases. These are enzymes. Once invasion occurs, or I should say once dissolution occurs, now we can have invasion. And we're going to end up with the neoplasm invading and what we call locomoting or locomotion through the basement membrane, invading tissue beneath it. Migration through this destroyed basement membrane and invading through the extracellular matrix is going to allow for it to further migrate and spread. We've spoken about this already, but malignant tumors need new blood vessel growth in order to grow. So once the cancer is larger than about a grain of sand, it needs its own blood supply. It needs its own blood supply so that it can get oxygen and nutrients, but also have a method of waste disposal. So this, that is the formation of new blood vessels, will allow a small cancer to become a large cancer. Now, with this process of angiogenesis, we'll end up with the release of chemotactic factors, which will diffuse at the site and help recruit and say, hey, we need help over here, and help recruit vascular endothelial cells so that they can build their own blood vessels. Enzymes such as the enzyme collagenase that was discussed earlier will further degrade the area around it in order to allow for connection to our own blood supply. Growth factors are going to be present. We specifically talked about the growth factors involved during our in-class lecture that will induce the formation of new blood vessels. Remember that normally new blood vessel formation is reserved for wound healing, but also for during the proliferative phase of the menstrual cycle in females. And so this is a very unique feature or characteristic that cancer cells have. Cancer's use of oxygen is an interesting concept as well. Normally our cells undergo oxidative phosphorylation for energy, and this is where we use glucose and oxygen to produce ATP, remembering back to your citric acid or Krebs cycle and your electron transport chain. Now, as you might recall, oxidative phosphorylation will produce at least 36 ATP because of the presence of oxygen. But without the presence of oxygen, we use glycolysis, which is anaerobic, which produces only 2 ATP. And when we talk about the yield here, this is based on 1 molecule of glucose. Now, this is under normal circumstances. Tumors and other proliferative tissues actually use anaerobic glycolysis, which produces lactate as a byproduct. And this is actually going to be used as a building block for tumors, which allows for rapid proliferation. The process is called Warburg effect, which is listed down here. And this causes the doubling of the normal 2 ATP that we would see under normal circumstances from anaerobic glycolysis, doubling it to 4 ATP from anaerobic glycolysis. So what this tells us is that the tumors and other proliferative tissue, but tumors of interest today, require glucose in order to produce energy, but they don't require oxygen. But what's interesting is that even when oxygen is present, the tumor prefers to use anaerobic glycolysis. So why does this matter, referring to what I just spoke about? Well, the scan on this slide is of a person that had a non-small cell lung cancer surgically removed 5 years ago and then came back in for a follow-up scan. And they've injected fluorodeoxyglucose, which is FDG, and FDG cannot be broken down because of a component that's missing by glycolysis, but it will accumulate in cells. And normally the only area that should be highlighted on this scan would be the heart, the brain, and the bladder that would show a strong signal. But what we can see has happened here is that it's lit up in many different areas here. The right shoulder, the mediastinal region, the cervical region, the liver, and the left part of the pelvis, the proximal femur. And this is a method, injection of FDG, and then having a PET scan to help determine if cancer has metastasized. And of course, in that case, it has, unfortunately, quite a bit. Here are the 6 main clinical manifestations or signs, symptoms, evidence of cancer that present that we're going to be looking at a little bit closer on the upcoming slides. So pain, fatigue, cachexia, anemia, leukopenia, and infection. In the early stages of malignancy, there is usually little or no pain, or at least not enough to warrant concern. But 60 to 80% of people diagnosed with terminal cancer will have pain. Pain is not just the stimulation of pain receptors, but oftentimes it's the interaction as well with your mental state. So psychogenic factors play a big role. There's also cultural expectations and physiologic components. Fear can play a role, anxiety, loss of your physical strength. Some possible mechanisms relating to the mechanisms of pain. Well, a main mechanism is compression of nerve endings. Also, obstruction of nerve or blood vessels can cause pain. Stretching of some of the visceral organs as well can cause pain. So a tumor in the stomach growing and stretching in the stomach, a tumor growing and stretching in the liver can lead to pain, among many other examples. Tissue destruction and inflammation can lead to pain, and then there's referred pain. So you can have cancer in one area of a bone that can refer pain to other areas because of a connected nerve supply. People with terminally ill cancer are usually very fatigued, and it can be rather difficult to discern exactly why. Is it because they can't sleep because of their pain, because of their stress? There might be trouble sleeping because of muscle loss that causes body fatigue. Muscle loss can occur because of biochemical changes from circulating cytokines or chemicals that can occur secondary to the disease, secondary to treatments. There's psychosocial factors, lack of physical activity, maybe poor nutrition status or environmental factors. For example, a person is spending a lot of time in the hospital because of their cancer, and that can be a noisy environment. There's a lot of different potential factors. Terminal cancer can cause cachexia, which is a severe form of malnutrition where there's extensive skeletal muscle loss and even adipose tissue as well. And these patients appear very, very frail and physically look unwell. And unfortunately, it's present in about 80% of cancer patients by the time of their death. Even if they do have adequate nutrition intake, their body is insufficiently using it. There can be a faster rate of protein, lipid, and carbohydrate use in the body with patients that have cancer at a faster rate than it's being formed. Patients can have syndromes that are similar to what you would see in a diabetic. There might be higher amounts of insulin in their blood. They might present with insulin resistance, excessive amount of glucose in the blood, increased formation of new glucose, higher levels of triglycerides in the blood from fats being broken down, and then muscle wasting that we spoke about. Common is anorexia at some point would be loss of appetite, and one of the reasons for this is because of early satiety. This means they feel fuller sooner and they stop eating because of that. Anemia is common as well, not getting enough iron and not being able to use it appropriately. Lack of muscle that we spoke about already can lead to marked weakness, which we call asthenia. Alterations in taste that can come from treatment such as chemotherapy. And then we already spoke about how there's altered protein, lipid, and carbohydrate metabolism, and we're using more than we're able to produce. I had mentioned that anemia was a potential clinical manifestation of cancer. In fact, 20% of patients will suffer from it, but the mechanism can vary. For example, it could be because they have a colorectal or genitourinary cancer that is prone to bleeding, and loss of blood can lead to iron deficiency regardless of intake. It could be malnutrition, not consuming enough. It could be that the cancer type that they have is not favorable for iron absorption. And it could be because of having chemotherapy. With chemotherapy, methotrexate, one of the chemicals, can kill bone marrow, and bone marrow is what forms our blood cells. A common therapy to combat anemia in certain circumstances is the use of EPO, which is erythropoietin. Erythropoietin is a hormone that is normally released in the body when we need more red blood cells to stimulate the bone marrow to produce more. But this does increase your risk of developing clots and therefore can reduce your cancer survival. So you have to look at risk versus benefit in that particular situation. On our last slide, we'll talk about the risk of infection, which would be due to the reduction in white blood cells, and the risk of bleeding, which would be due to the reduction in platelets. In terms of causes, well, tumors can directly invade bone marrow. In this case, they can impact the bone marrow's ability to produce all forms of blood cells. In other cases, as I started to mention on the previous slide, chemotherapy drugs and radiation can cause the bone marrow to stop producing the same amount and quality of blood cells that it normally does. And when we see a reduction in white blood cells, for example, neutrophils and lymphocytes, this can lead to immunosuppression because we know they play such a big role in our immune system. And so oftentimes in these cases where pathogens normally wouldn't be a problem, they are going to become more of an issue. These patients are also more likely to suffer from nosocomial infections. We talked about these as being infections acquired by being in a hospital environment. And thrombocytopenia, which is the reduction in the normal amount of platelets also produced by our bone marrow, mean that you're now at risk of bleeding, referred to as hemorrhage. That's the end of today's lecture. Thank you so much for your time.